We'll talk about HPV reactivation, mainly in the area of newer immunosuppression and immunomodulators. I have nothing to disclose. And as far as the objectives today, one, we want to understand the risk of HPV reactivation, review the current body of evidence for risk stratification, and determine management strategies for prophylaxis. So just as an introduction, let's talk about the disease burden of hepatitis B. So the incidence of HPV reactivation with each class of immunosuppression or immunomodulators is highly varied due to the lack of consensus regarding definitions, variations in study design and patient selection, which is a constant theme you're going to see through this presentation, where the definitions changes between one study to one study, as well as the low number of patients usually in these studies. So the current literature says that B-cell depleting agents such as rituximab are associated with the highest risk of reactivation. And as far as the disease burden, one systemic review reported that liver failure among surface antigen positive patients and core positive with anti-cancer therapy is 13.9%. And previous studies have also showed the reactivation rate for anti-cancer therapy in the range from 41 to 53 in surface antigen positive patients, and then in surface antigen negative but core positive 8 to 18%. For rheumatic diseases, the rate has been 12.3% in surface antigen positive patients, and if only the core is positive, then it's 1.7%. So I found it a good idea to start with some definitions just to set the stage. The best definitions are with the AASLD guidelines from 2018, which basically defined reactivation in surface antigen positive patients as one of these three. So either a 2-log increase in DNA compared to the baseline, or a 3-log in a patient with a previously undetectable level, or a 4-log if your baseline level is not available. And then for surface antigen negative patients but core positive, it's either a detectable DNA or reverse seroconversion. They also defined the hepatitis flare as an ALT 3 times upper limit of normal and more than 100. So usually we risk stratify them into high risk, that's more than 10%, or moderate risk 1 to 10%, or low risk, that's 1%. Obviously, with these newer classes of immunosuppression and immunomodulators that have been in clinical use, data has been sparse on these new medications. So for screening, almost all of the guidelines agree on the surface antigen and the core antibody. The next question is for the role of antibodies, anti-HBs, in the screening. So these have not yet been well established. However, in individuals with surface antigen negative and core positive, the presence of and titer of surface antibodies have been associated with some protection against reactivation. However, that presence does not prevent HPV reactivation, although the surface antibody may be useful for detecting past infections in surface antigen negative patients and core positive patients, and in surveillance, given that the loss of surface antibody may be a predictor of reactivation. Of note here that the AGA guidelines actually recommend against using the surface antibody. So that's basically the summary of the guidelines and their use for surface antibody. So for the AASLD and the AGA, they do not recommend it, but for the EASL and the Asia Pacific guideline from 2021, they do recommend it. So we'll just, before we head into individual medications, we're just going to review the evidence from these guidelines, the EASL 2017, AASLD is 2018, and EPASL 2021. So for the EASL, they make things relatively simple. So all candidates for chemotherapy and immunosuppression should be tested for HPV markers prior to immunosuppression. And if you are surface antigen positive, you should receive medications. However, if your surface antigen is negative and your core is positive, you should receive prophylaxis only if you are a high risk of reactivation. 1 year later, the AASLD almost made a similar guideline, which basically says that surface antigen positive patients should receive prophylaxis, and if you're a surface negative but core positive, you you should be carefully monitored with ALT, HBV DNA, surface antigen, with intent of on-demand therapy. They made an exception for patients with high risk, that's CD20 and stem cell transplantation. So once you start the prophylaxis, you should continue during immunosuppression therapy, and for at least 6 months or at least 12 months if you're using CD20. And for patients being monitored without prophylaxis, DNA levels should be done every 1 to 3 months, and they should be monitored for up to 12 months after cessation of anti-HBV therapy, as the reactivation can also follow discontinuation of these immunosuppressions. The PASL guidelines 2021 so divided in 2 things. One, it's mandatory and life-saving to administer medications to the following patients. So high-risk patients, all of the patients should be receiving treatment, whether your surface antigen is positive or negative. And in moderate risk groups, all surface antigen positive and those with core positive with advanced liver fibrosis or cirrhosis. And to a lesser degree, they recommended for low-risk groups with surface antigen positive or only core positive with advanced liver fibrosis or cirrhosis. So the real change that has happened here compared to the EASL and AASLD is the addition of the fibrosis assessment. So this is actually a good meta-analysis that was published in 2022 Journal of Hepatology by Papatheodorou and colleagues that we're going to delve into. So it included 59 studies with a total of 9,223 patients. 3,400 of them were surface antigen positive. 5,800 were core positive. So we're going to talk about it when we talk about the individual medications now. So starting with the older medications, so anti-TNF. For surface antigen positive patients, anti-TNF have been reported to be associated with reactivation risk between 14 and 63% among a relatively small case number in published series, with abatacept being more than others. Back to the meta-analysis by Papatheodorou. So anti-TNF agents, there were 18 studies in that meta-analysis, including 1,640 patients. Those were surface antigen negative and core positive. 76 of them received NA prophylaxis with a pooled incidence rate of reactivation 1% overall, as well as in the 1,564 patients not receiving NA prophylaxis. And reactivation was reactivation was not observed in any of the 76% patients receiving prophylaxis. Only 1 out of 1,481 not receiving prophylaxis developed reactivation. And none of these patients in all of these studies developed hepatic decompensation or died. So that's just a summary of the studies they included when they look at anti-TNF. If you look at the right side of the table, you notice that this discrepancy in defining what is hepatitis. For example, some study will define it as more than 10 upper limit normal, while others only more than 2. Also, the definition of reactivation is varied between studies. So in summary, AGA says it's moderate risk for activation for anti-TNF, and then APASL said for surface antigen positive, that's high risk, especially for agents with higher potency. And if only the core is positive, it's considered as moderate risk. For anti-interleukin antibody therapy, so as a group, compared to anti-TNF, it had a lower risk of reactivation with a hazard ratio of 0.24. And ustekinumab, there was a study by Ting, SW, and colleagues 2018 where 54 patients were classified as inactive HBV carrier, resolved HBV infection, or isolated anti-HBV core positivity. 10 chronic hepatitis B patients, 44 resolved HBV, and HBV DNA at baseline negative. Prophylaxis was given to 2 patients with chronic hepatitis B. The average duration of follow-up was 24 plus minus 1 year. And then reactivation in 2 patients with chronic hepatitis B without prophylaxis. However, they did not develop hepatitis. And 1 patient with resolved HBV with mild hepatitis. None of these patients had liver failure. And for surface antigen positive patients, another study of 11 patients, 2 out of the 7, that's 29%, did not receive antiviral prophylaxis, exhibited HBV reactivation during treatment. So So it demonstrated a 29% rate of reactivation after ustekinumab initiation without antiviral prophylaxis in patients with chronic hepatitis B. For ustekinumab, actually a recent study, SIOFI in 2023 was published, where it's a multi-center Italian retrospective cohort study, 26 patients, psoriasis patients, and HPV infection. So 11 of these patients had HPV infection, that's a 47%, and 7 patients had previous or occult infection, and 8 patients had resolved infection. Surface antigen positive patients were given prophylaxis except 1 patient with undetectable PCR. The good thing is that none of these 26 patients developed reactivation, including the patient with positive surface antigen not receiving prophylaxis. For guselkumab, so if you look on the left side of the table, there is a study by Huang, published May 2024, Journal of Dermatology. So these are psoriasis patients, 84 patients with hepatitis B virus, 13 of them surface antigen positive. The rest were surface antigen negative but core positive. So we'll start with the surface antigen positive patients. 10 of them received prophylaxis, and 1 of them had reactivation. However, that patient was closely monitored by a hepatologist without antiviral treatment and with continuation of the medication. He had eventually improvement in the DNA and liver enzymes. On the other side, patient who did receive prophylaxis, 1 patient had reactivation. Of note, that patient had stopped his medication due to reimbursement reasons. 2 months after stopping the medication, he developed the reactivation. That patient also did not require antiviral treatment, and they just continued with monitoring with eventual improvement of the LFTs and the DNA. On the other side, patients with surface antigen negative, core positive, they divided them into surface antibody positive and negative. However, all of these patients did not develop reactivation. For mirikizumab, I did not find actually any studies for reactivation of Hep B. However, you can extrapolate from mirikizumab and ustekinumab given the similar mechanism of action. For anti-interleukin therapy as a group, they're considered moderate risk of reactivation by APASL. So while these guidelines, whether it's EASL, APASL, and ASLD, recommend preemptive therapy if DNA is undetected, further studies are warranted, especially the newer medications with no long track records of HPV reactivation monitoring. So as with the other medications we're going to discuss, most of these medications are used in the setting of other immunosuppression or on the back of using steroids. So that's also something to consider where you're considering the reactivation risk. For anti-integrin antibody therapy, VIDO, so it's a potent immunomodulator agent, may be capable of causing reactivation of hepatitis B. We're just going to go fast with this study. That's by Lin WC 2023. So it has almost 260 patients, 260 patients, 14% of them and 7% of them were UC and CD respectively, had Hep B. Positive result for surface antigen was found before VIDO initiation in 15 UC patients and 7 CD patients. So they gave antiviral prophylaxis according to the guidelines, except some patients who did not fulfill the reimbursement criteria. And then only 1 patient had experienced reactivation. However, the clinicians suspect that that reactivation is not really due to the VIDO, and they attributed it to the recent tapering of steroid and azathioprine dose escalation. So the basic thing is, to date, however, no concrete evidence has linked vedolizumab or natalizumab, for that matter, the medication for MS, to clear incidence of reactivation or a clear link. For JAK inhibitors, so for baricitinib, it's appeared to have the strongest signal among the JAK inhibitors based on the highest reporting odds ratio. There was 1 study in surface antigen negative and core positive patients, and none of these 213 patients received prophylaxis. Reactivation was observed in 30, that's 14% of these patients. However, none of them developed really hepatitis or liver decompensation. For tofacitinib, a study by Wang and colleagues, 2021, that was the best study there, with 98 patients with RA were enrolled. So 8 of them had surface antigen positive and 64 were surface antigen negative, core positive. So in the surface antigen positive patients, 2 patients received prophylaxis. None of them had reactivation or hepatitis flare-up. The reactivation rate was 33%, 2 out of 6 in the surface antigen patients without antiviral prophylaxis. However, given the low number, I'm not sure how much we can conclude from here. So among the surface antigen negative patients, core positive patients, the reactivation rate was 3.1%, with an incidence rate of reactivation 153 per 1,000 years for overall surface antigen positive patients, 250 per 1,000 years after excluding patients receiving prophylaxis. So incidence rate was 11.2%, 11.2 per 1,000 person year for surface antigen negative core positive patients. And then another study for TOFA was a retrospective cohort study that included 6 patients with chronic hepatitis B, showed that 2 out of the 4 without prophylaxis developed reactivation after starting TOFA. 1 patient had an elevated ALT and started entecavir, resulting in decline in DNA and ALT level. Another patient started entecavir and did not develop acute hepatitis. And both these patients continued TOFA after the development of reactivation. Meanwhile, 2 patients with chronic hepatitis B who received antiviral prophylaxis did not develop reactivation after initiating TOFA. So further in the study, none of the 5 patients who with resolved HBV received prophylaxis and no reactivation in those groups. And finally, for TOFA, another study demonstrated that 8 patients with resolved HBV did not develop reactivation after starting tofacitinib. For upadacitinib, I didn't find any solid evidence there for reactivation. However, of note, there was one published case report in ACG 2024 by Khan, where there was 1 patient with RA, E antigen negative chronic HBV infection with normal LFTs, normal fibrosis prior to initiation of medication. He used upadacitinib without prophylaxis against HBV and developed reactivation after 5 months, with unfortunately leading to fulminant hepatic failure necessitating emergent liver transplantation. For S1P modulators, so for ozanimod and etrasimod have not been clearly linked to cases of reactivation of Hep B. However, their older sibling fingolimod, which is used for MS, has been linked to cases of acute liver failure requiring liver transplant and significant liver injury. There was also 1 case of reactivation with fingolimod in a surface antigen positive patients. That's a 41-year-old Taiwanese woman with relapsing MS, inactive surface antigen carrier state, who developed reactivation after 35 months of treatment with rise in LFTs. The patient responded well to tenofovir with resolution of ALT and decrease of DNA without having to stop the fingolimod. So this is really a nice summary by EPASO guidelines, that's in 2021. Where they basically divided it into groups of risk. So starting with the high risk group, if you're on the right side of the table, if you're a surface antigen negative, that only includes really CD20 patients as well as allogeneic hematopoietic stem cell transplant. On the other side, if you're surface antigen positive, obviously it's a much bigger group of medications. So other than CD20, they included high doses of steroid, defined as more than 20 per day for more than 4 weeks, as well as anti-TNF agents with higher potency, anthracycline. They also included hepatitis C medications, except for non-cirrhotic or surface antigen less than 10, immune checkpoint inhibitors, tyrosine kinase inhibitors. And then for a definition of moderate with surface antigen negative, so anthracycline, anti-TNF agents with higher potency. And then the opposite side with surface antigen positive, they added steroids and proteasome inhibitors, including ustekinumab. And the low risk of activation is obviously azathioprine, methotrexate, lower doses of steroids. So that's a really nice algorithm that they have included in the guidelines. It really summarizes things nicely. So the good thing is that the addition of liver fibrosis assessment. So if you're high risk, that's straightforward. You go to nucleoside analogs. If you're moderate or low risk, you do the liver fibrosis assessment. If you have advanced fibrosis or cirrhosis, you initiate treatment. Just one more slide. So what about adherence to guidelines? We did listen to a lot of guidelines, a lot of studies, but are we really adhering? So this recent study, 2024, said that out of 6,200 patients, the proportion of patients receiving appropriate reactivation management were only 43% for high-risk patients, 40% for intermediate, and 14% for low-risk patients. So in summary, the advent of potent and safe antiviral therapy, for example, nucleoside analogs, have provided long-term suppression of HBV replication. It introduces an effective management strategy for these patients. And as a matter of fact, several studies, meta-analyses have shown that prophylactic NA therapy significantly reduces the risk of reactivation-related hepatitis or liver failure. And finally, just note that these are newer medications, so not a lot of body of evidence there, so individualize your decisions. It's better to be safe with newer medications overall, especially in the kingdom. A lot of the limiting factors in these studies was mainly insurance purposes, reimbursement purposes. Probably can be more liberal here in Saudi Arabia when it comes to decisions to treat. Thank you.